Okay, start.
Okay, so just imagine that this child is being examined in an OPD. So this is a 6-year-old child who has been examined in an OPD or a hospital setup. So which is who is basically being examined in the hospital setup. Okay, so in this examination, the what we are getting is that the child and just think that these points are coming on the screen, that the trachea is being examined and it is central. There is no distress that the child is presently having, and there is reduced movement in the right side. Just think there is a sticking also which is there on the right side. Okay, and there is reduced breath sounds in the right lower zone, and there is reduced vocal resonance also in the right lower zone.
Okay, wait, I will tell you. Trachea in the center, okay, and reduced movement on the right side, reduced breath sounds on the right lower zone, and reduced vocal resonance. What else, Dr. Muzna? Not in distress, right?
Not in distress, and a dull note on percussion also.
And dull note on percussion on right side. Lower chest or what?
Lower lobe means from the third intercostal to down.
Okay, is it clear?
Yeah, it's clear.
Okay. So 2 minutes and then we will start. The age of the child, you said 8 years, right? Okay.
So please describe the signs that you have seen.
Okay, I can see a child who's on respiratory examinations. The trachea is in the center, and then there is a diminished chest movement on the right sides, and then there is decreased breath sounds on auscultations, and then the vocal resonance is also reduced on the right basal regions. So with these findings, my working diagnosis would be there could be a pleural effusion on the right lower side of the chest. Could be because of the infections like pneumonia, or could be because of the tuberculosis or any other hypoalbuminemic state, just like hypoalbuminemia due to liver disease or due to the kidney conditions like nephrotic disease or any liver conditions.
Which conditions do you think are more likely, which you have mentioned? Is nephrotic and hypoalbuminemia likely? If yes or no, why?
Can you rephrase your questions, please, Nuzna?
Sorry, Amit, I'm trying to say that the causes that you mentioned, like nephrotic and hypoalbuminemia, is it likely in this case? And is it likely in this case?
No, this is unlikely, but it could be possibility. That is the reason I kept on the down list. But most looking at these conditions, since he is not in distress with the pleural effusions in our part of world, the tuberculosis effusion is quite common, and then it's number one.
Okay. What will you ask in the history?
So I'll be asking about the associated symptoms such as fever, night sweats, weight loss, pertaining to the tuberculosis, and or pertaining to the pneumonia or the lower respiratory tract infections. And then I'll be asking about to see if there is any swelling of the face or swelling of the legs or abdominal distensions associated with this effusion, to look for any generalized hypoalbuminemia, generalized swelling due to hypoalbuminemia due to nephrotic syndromes.
Okay, what will you see in the examination?
on the examinations, as I mentioned, that the breath sounds would be diminished on the affected side, and then the on auscultations, there will be on auscultation will be diminished breath sounds, and then on percussions there will be stony dullness, and there will be diminished vocal resonance on the affected sides.
Why is the trachea not deviated? Is it deviated in pleural effusion?
If it depends upon the quantity of like how massive the pleural effusion is. Okay.
Okay.
If it is a small quantity, the trachea would not deviate.
Okay. Very good. So how would you manage this child?
The management of these cells would depend upon the conditions, underlying conditions. First of all, the child is not in distress. So after the history, and then after the proper history and examinations, I'll be doing the baseline blood test, such as complete blood count, CRP, ESR, and then in infections, it would be the inflammatory markers will be raised, such as CBC and CRP. I mean CRP and the ESR, and then I'll be sending the blood culture as well, and then I'll be doing the baseline liver function and the renal function test, and I'll be doing the urine depistics as well, and with the imaging, I'll go for the chest X-ray, and the chest X-ray I would expect the haziness and the blunting of the right costophrenic angle, and then on terms of further investigations, I'd be doing the pleural fluid tapping, thoracocentesis, to analyze the fluid by USC guided, and then I'll be sending the pleural fluid for Gram stains, and then protein, sugar, and then as well as staining for the Gram staining and culture sensitivity. And for tuberculosis, which is quite common, I'll be going for the even for the pleural fluid ADA level as well, and then we'll do the BCG test as well for the child. And
how will you differentiate on pleural fluid, transudate and exudate?
So it will basically the transudative fluids will be clear in nature, and then whereas the exudative will be thick in the cross examinations. And in terms of the protein, the exudative will be having more protein than the transudative. It will be more than 3.5 gram per liter. And the exudative will be having will be having the more WBC, and then I think this much.
Okay. And what medications would you, how will you further treat this child?
Okay, so I'll
6 minutes.
If I say that they,
but you can
okay,
continue. You can continue.
okay, if I say that there were bronchial breath sounds that were there, and this had an underlying pneumonia which led to a pleural effusion, then what will be your management?
Okay. So since the child is not in distress, I would expect the child is pink in ear and maintaining saturations. As for respiratory cases, for managing any children with then we need to assess for the airway breathing and circulations. And then once these things are stable, then we'll be giving the IV antibiotics, preferably the third generation cephalosporins, and then changing to the antibiotics according to the culture and sensitivity. And in terms of these effusions, then if it is loculated infusions, then we may need a drainage with consultations with the surgeons for possible intercostal tube placement. And sometimes we may have to use the medicines to lyse the adhesions, I mean the septations, by the help of streptokinase, which will helps to
Urokinase is correct. Intrapleural
yeah,
fibrinolytics. Yeah.
yeah, fibrinolytics, and
Okay.
then this
When will you involve the respiratory pediatrician in this case?
so the respiratory pediatrician has to be come to in this scene after consulting my consultant since the beginning, because the pleural effusions has to be drained, and then we need the help to further manage this condition.
Okay, and how will we further? How long are we going to give IV?
So IV medications for the child will be till his condition improves, and then when he is when the child is able to tolerate orally and his conditions are better, then we can switch to systemic oral antibiotics.
How long will you continue the antibiotics?
So depending on the organisms, and then it may last for even like 4 to 6 weeks.
Which antibiotic will you start in a hospital-acquired pneumonia with pleural effusion?
Piperacillin and tazobactam.
Excellent. When will you arrange a review after this child gets discharged? After how much time will he review back?
So since this child if the child has undergone the chest tube drainage, then I would expect him to come in a review in quite early, in a couple of maybe 1 or 2 weeks time, but it depends upon the hospital policy, and then I'll better ask my consultants when he can be seen, but I would expect him to come early.
Okay, how will you clinically differentiate between a transudative and an exudative pulse?
Clinically?
Yeah, clinically. Something which is generally goes more in favor of a transudate rather than an exudate.
By gross inspections, the transudate will be clear, right?
Okay, means clinically not the fluid, clinically the patient. Like if it's a bilateral pleural effusion, what do you think?
Okay,
Will
yeah.
it be a transudate or an exudate? If it's a bilateral pleural effusion.
So the transudate will be it will be bilateral, whereas the exudative will be localized.
Yeah, excellent. Right. So I think that's it.
And
Feedback. Okay,
Dr. Muzna, the protein and this LDH ratio will be more.
That just thing is that is
okay, just wait. Don't give any feedback because Dr. Saria, she wants to do.
Okay.
Okay. Dr. Saria, you're here. You want to do?
Yes, please let me to try. I didn't do video before at all.
Okay, Dr. Saria wants to do. She messaged me, so she will do now for 6 minutes only. Then we will do the discussion. Okay, I will keep the time. You want time or you will start, Dr. Saria?
No, it's okay. Let us to start.
Okay, so please.
He's 7 years old.
Yeah, 7 years old. Not in distress. Trachea and central. Air entry decrease on the right side. There's a sticking on the right side. Percussion dull note on the right side, and breath sounds decreased on the right side.
Okay.
Please explain your
So I
findings.
can see 7 years old boy looks in a hospital setting, not in distress, not connected to oxygen or monitor. Okay. In the examination, the local examination to the chest, there is decreased air entry in the lower right side with decreased percussion tone also, dullness in the lower right side. No obvious dysmorphologic in the chest shape, not in distress, no subcostal retraction or suprasternal retraction, right?
Yes, proceed.
You are describing your findings, huh, Dr. Saria?
Yes.
So, okay.
Yes.
Then what are your differentials? Okay, for example, you've explained. So what are your differentials now?
Okay, from the local examination, my differential, almost this patient has pleural effusion on the right side. It could be oxidative or translate according to the underlying cause. If it's oxidative, almost it will go with the infection, like pneumonia, tuberculosis, malignancy, cystic fibrosis. If it's translate, it will go with the heart failure, nephrotic syndrome, portal hypertension, and others.
Okay. So what will you ask in the history for this child?
Okay, first I will ask about the respiratory system. If this child has any cough, fever, when it started, for how long? Then I will ask also about his general activity, if he has any chronic illness, if he has any contact with any sick patient or patient with coronavirus, chronic illness like bronchial asthma or any cystic fibrosis, diabetes, any chronic illness, heart disease or renal disease, chronic liver disease also. I will ask about vaccine.
Going to examine in this child?
Sorry?
What will you examine in this child?
I will complete the full respiratory chest examination, full chest examination. Then accordingly, I will do general examination for the patient. I will take his vital signs, his temperature, saturation, respiratory rate. Okay. Then I will just already we did, right?
Okay, fine. So besides the chest, any other system you want to
Yes.
examine?
Yes, I will check his heart also if he has any other third space collection fluid like ascites or lower limb edema, edema. I will check all of this. Clubbing.
Okay. Then how will you manage this case?
First of all, I will take a blood workup to see if there is any signs of infection, CBC, CRBSR. Then I would like to do X-ray, just X-ray, to see if there is a real perfusion. I will prepare also to do chest ultrasound to see the amount of fluid. Okay.
What all did you come to know in your ultrasound?
Sorry?
How will ultrasound help you in this case?
Ultrasound can assess the amount of pleural fluid the chest, plus the general condition of the baby also. But if the high amount, that time maybe the patient need to insert chest tube, guided also by ultrasound.
Okay, very good. Anything else you would like to do for this child?
If I took the pleural effusion fluid, I will send for analysis and culture. Also, if the general signs and general condition for the baby going with the infection, I would like also to take a sputum for culture. What else? Pleural, I sent over pleural effusion, pleural fluid, and sputum. Yes, this is the move.
Okay, how will you further manage this child?
Sorry, how?
Treat this child. How will you further treat this child?
Okay. If the patient in distress, and the VBG, I will do VBG if he need any releasing of the fluid. So I will insert chest drain to release the fluid. This is then I will see accordingly if it's going with the infectious disease like pneumonia or TB. Then we will start the antibiotic. For this patient,
choice of antibiotic if this is a community-acquired pneumonia leading to pleural effusion.
If hospital acquired, in this case,
Not
it's
hospital,
complicated.
community-acquired.
community acquired, okay, with amoxicillin, but this is a complicated with pleural effusion. So amoxicillin clavicular. So we will
This
continue.
amoxiclav covers staphylococcus.
Yes, because of the staff. So almost it's staff due to, because it's associated with pleural effusion. So I will start. We will continue antibiotic for 2 weeks, as I remember. Yeah.
Okay. When will you involve the respiratory pediatrician?
I will go to respiratory pediatrician if the patient didn't improve. Okay. If persistent pleural effusion, maybe we need to do that time CT chest. Patient is not responding to antibiotic, second antibiotic.
6 minutes now, but if you want to continue, can continue.
I think it's done, doctor.
Okay.
The last question, I don't know.
Okay. Okay, good. At least good try, Dr. Saria.
Thank you for giving me this chance.
Okay, most welcome. So give your feedbacks for both of them, no problem. You can start.
Alhamdulillah, both of them did very nicely, and most of the points were covered.
I feel your wait, Dr. Muzna. I feel your sound is little far. Can you make something to make
I'll once again get my laptop.
Yes, and it's I don't know. I cannot also hear well. It's interrupted.
She will arrange her.
Okay, now I'm clear.
Yeah. Now you are very clear.
Okay, okay, fine. So Alhamdulillah, both of them did very nicely, and very means most just a few points here and there, but it's absolutely pardonable, I feel. Okay, so just this when I asked about the pleural this the symptoms, that what would you ask in history? I think I'll just missed out on vaccination, history of vaccination that was there. Weight loss, both of you all covered chest pain and everything. All the liver and renal part also you all covered. Okay, and examination, I just start with the vitals. Okay, Dr. Saria Alhamdulillah did with the vitals, and the chest has been done, but of course examination of the abdomen system also, to see whether there is pleural effusion which is associated with ascites or no, whether and whether even the cardiac you all rightly covered. Okay, then even for I think none of you all mentioned lymphadenopathy. TB was one of your DDs. I don't remember you all mentioning that you will check for the lymphadenopathy. You must have mentioned. I must have missed it. Okay, and regarding the investigation,
not mentioned.
Okay, just blood culture, Dr. Saria, that you did say. Otherwise, Alhamdulillah, things were all fine, very well. And sonography, the part was why you do that will be to diagnose the minimal amount of fluid for aspiration and for complications with pleural effusion that can happen, like loculations, cavitating problems, or if it's a heterogeneous, whether it's an empyema or this pleural effusion, the sonologist will be very good at telling you all that. Okay. Pleural fluid analysis, Dr. Amit covered very nicely in detail. Just a few things from the patient info, that light criteria to be put, that there is a ratio of pleural fluid protein is to serum fluid protein. If that is more than 0.5, or a pleural fluid
yes,
LD,
we have to compare with the serum also. I forget to mention that.
Also.
Serum.
Just an isolated value does
Protein
not
and
hold well. So the protein being compared, first the pleural and then of course the serum being more than 0.5 and LDH more than 0.6. Okay, or pleural fluid LDH being more than 2/3 the serum fluid, then that is very much in favor of an exudative problem. Okay, and after that the choice you all mentioned, both of you are very nicely, ABC, oxygen, analgesia. Just in the treatment, the IV drug of as per the PEDIA guidelines, just remember pneumonia or pleural effusion, the first drug is coamoxiclav. However, coamoxiclav does not cover stack to that great extent. Hence, we add Clinda. Okay, so clindamycin has to be given. Hospital acquired, Dr. Amit rightly said, piperacillin, tazobactam, that needs to be done. If I tell you this is a tuberculous effusion, then what will your drug of choice be?
Antituberculous drugs.
I will consult the TBT. That's going to be the answer. Okay. And yeah. I'm sorry, my children are just around me. So and after that,
And for how long?
Please pardon. How long? That is going to be 2 weeks. Okay, 2 weeks. The answer is complete minimum 2 weeks of antibiotics. If there have been certain complications, then consult once again. We are just going to channelize people here and there, so we'll consult the respiratory physician. Okay. When do you refer to respiratory physicians? Early refer most of the cases. Okay. The cases which you don't have to refer are mentioned over here. A very small pleural effusion, which is not enlarging and not compromising the respiratory function. That one does not need drainage. That does not have to be referred. Otherwise, rest all refer. So once again, refer all except the ones which are small, not enlarging, and not distressing. Okay. And the chest drain needs to be put with the respiratory. Okay, that is done. And Dr. Amit rightly covered about the intrapleural fibrinolytics. When do we give intrapleural fibrinolytics indication?
So when the USG shows the septations.
Very good. Loculations,
Localizes
and pus. Yeah. So urokinase, it's not the streptokinase, it's urokinase. Okay. And when do we shift from IV to oral? Is when the child becomes afebrile and CRP is falling to 10. Okay. So that's what rightly you all mentioned, that he's getting better and he's responding and he can take orally. At that point of time, you can. Okay. If it's non-resolving pleural effusion, okay, after 3 days, and if there are more complications, go on for a CT scan. And this discharge after 6 weeks, say they are saying that after 6 weeks of discharge, kind of keep the follow-up with the respiratory physician. But if the symptoms persist or recur, come early.
6 week follow-up?
Yeah, 6 weeks follow-up means after the child gets discharged, he's fine, absolutely. Come to the respiratory physician after 6 weeks until and unless there is some other warning sign that comes up. Okay.
Okay. Is this there in the red book you're reading from?
Yeah, red book.
Can you tell me the page number?
228.
Okay.
Assalamu alaikum.
Walaikum salam.
I want to add something to the history. Can I do? Okay. Nobody asked about the history of trauma. To think about the hemothorax. Other thing, we should ask about the recurrent chest infection. To think about the immunodeficiency and HIV can complicate it with a pleural effusion. Other thing, history of weight loss for especially tuberculosis infection. I think the first doctor he asked it, but the second doctor, he didn't ask.
Dr. Ala, I'm really sorry I missed the last point. It was unclear.
The last thing, the history of weight loss.
Yeah,
I think they mentioned weight loss. Trauma, yes, I think they missed, but weight loss, I think one of them covered.
Thank you, Dr. Muzna, and thank you, Dr. Noor.
Okay, you are welcome. Just quickly we will go through. So
Okay,
here for
sure.
pleural effusion, symptoms and signs, investigate for effusion if persistent pyrexia or unwell 48 hours after treatment started for pneumonia. Okay. Next is differential diagnosis. You can have uncomplicated pneumonias, malignancy, heart failure, pancreatitis, and even pulmonary embolism. For investigations, full blood count and clotting screen, urea and electrolytes, LDH, protein, albumin, glucose, CRP. I think all these things were covered. Then blood cultures, sputum culture if possible. If recurrent infections, investigate for immunodeficiency. Again, the first line for immunodeficiency is full blood count, IgG, IgA, and IgM, and functional antibodies and HIV antibody. Chest X-ray, PA or AP, no need for lateral. Ultrasound scan to confirm presence of effusion. Maximum depth in dependent position. Differentiate between simple and complicated effusions. Example, loculations, heterogeneous material, localized effusion at time of drain insertion. If history, chest X-ray or ultrasound suggestive of malignancy, request CT chest. So you'll request CT chest only if there is suggestive of malignancy. If risk factors for coagulopathy or thrombocytopenia, check and correct before drain insertion. So in your this you should also mention the clotting screen. That's why. Then pleural fluid analysis for gram stain, bacterial culture, differential cell count, cytology, and TB, PCR, and culture. What is the AAFB?
Acid fast bacilli. Okay. For
Maybe atypical acid fast bacilli, first one, or what?
misprint, I don't know.
Okay, let's see. If cause is likely to be infective, it is not necessary to obtain sample for pleural fluid culture routinely before chest drain insertion. If alternative cause suspected, try to avoid unnecessary chest drain insertion by obtaining diagnostic aspirate of pleural fluid for cytology. Okay, so if cause is infective, you don't need to obtain a separate sample for pleural fluid culture routinely before chest drain. So when you do the chest drain, at the same time you will collect the sample. If alternative cause other than infection, you think the other causes is suspected, try to avoid unnecessary chest drain insertion by obtaining diagnostic trap of pleural fluid for cytology. You can just get the diagnostic tab. So immediate treatment supportive, again start with ABC, oxygen and fluid resuscitation as needed, and analgesia. So antibiotic therapy is very important. Effusion following community acquired pneumonia, amoxiclav IV or clindamycin IV. If penicillin allergy, only clindamycin. Effusion following hospital acquired pneumonia or from trauma or aspiration or immunocompromised child, you will go for piperacillin and tazobactam. And if allergy, clindamycin. Effusion, possibly tuberculosis, discuss with TB team. This is what she was telling. Okay. Narrow antibiotic spectrum with culture results. When do you refer to respiratory pediatrician? Early active treatment reduces the length of illness. Except small effusions less than 2 centimeter deep, which are not enlarging and compromising respiratory function, do not need to be drained. Underlying cavitating disease may lead to bronchopleural fistulae. Okay. So chest drain insertion type, I think we no need. So what are the teams involved here is the respiratory team, consultant pediatrician, pediatric anesthesia team, usually GA is used. Support may also be required from cardiothoracic team and interventional radiologist. Okay. So they are asking chest drain management or something. Any idea? So I think enough. Rest of the things you can read. This is just 2 pages, not much. So Dr. Musna, you have anything to tell or finished? Hello?
They can ask us for in more details how to replace fluid or anything like this.
Maybe we are not sure. They can ask anything. Anyone knows the answer? Like usually the fluid replacement again depends upon the dehydration status and also the cause. Like if it is nephrotic or something, you will be careful, right? You will give 10 ml only if it is shocked like this. So you can also, it will depend upon the cause, not only just fluid replacement. But I don't know, it's given in guidelines, I believe. You can just go through these 2 pages which we read. Most of the answers you will get it.
We done from today to Turner, the cases for today.
Yes, we are done with the cases. I'm just trying to see, just before ending, to go through the
I have a small question. Before we did thyroid, right? Thyroid examination.
Yeah.
Just I want to ask how I will go in the general examination first, then I will go to the thyroid. I will start with the hand, then local examination, then I will complete the other signs of thyroid, like reflex and all of these things.
Yes, so general examination is very important in any case. You have to go for the hands, comment on the hands, and if the child is, and also pulse is very important in thyroid. And then you will go for axilla. If the child is pubertal age, you will comment on any axillary hair growth. Then eyes, face, mouth, neck. When you come to the neck, then you will continue your thyroid examination. This is what is your question, or you have anything else?
Yes. Thank you.
I'll just read some points about Addison's crisis here. If the level of cortisol falls to become very low, you can become very ill in a short time. This is called Addison's crisis or Addisonian crisis. In this situation, symptoms include severe vomiting and diarrhea, pain in the back and abdomen, lack of fluid in the body, dehydration, low blood pressure, collapse. If you see our patient, when she presented to emergency, I had given in the case that the patient had vomiting and diarrhea and had dehydration. This was the information given to the candidate. Okay, so they can come first time also before diagnosis with Addison's crisis, like diabetes can come with DKA. Okay, so the symptoms can be severe vomiting and diarrhea and lack of fluid in the body, dehydration, low blood pressure and collapse. and pain in the back and abdomen. You may become severely ill and may die if the cause of the symptoms is not diagnosed and treated quickly. An Addisonian crisis may suddenly develop after a period of less severe symptoms described above. So, over a period of 3 months, our patient had symptoms, but they were less severe. But suddenly, with vomiting and diarrhea, she had severe symptoms of crisis. Okay. The crisis is often triggered by another illness, such as infection, or a stress such as surgical operation, infection and surgical operation. During these times, your body needs extra cortisol. But if you have Addison's disease, you cannot make extra cortisol. You may then quickly develop crisis symptoms. In some Addisonian, in some cases, Addisonian crisis develops when there have not been any previous symptoms. Okay. I think here this article is going like the leaflet for the layman's, but still it can give some information for us, like blood tests may help to point Addison's disease. These include measurements of some of the salts, that is sodium and potassium, sugar levels, that is glucose, calcium, and monitor cortisol levels. Okay. A one-off measurement of blood cortisols, however, may not be enough to diagnose Addison's disease. So you have to go for this synactin test, okay? Which you can read about the synactin test, which we all know.